Well, welcome everyone to our first National Myeloma Month online seminar, and I'm glad to be here with you. My name is Mark Henderson, and I'm very fortunate to be the Chief Executive Officer of Myeloma Australia. Before we start today's presentations and discussions, I'd like to acknowledge the collective lands that we all meet on today, and I'm situated on the land of the Wathaurong people, and I wish to pay my respects to their elders, past, present, and emerging. I also want to pay my deep gratitude and thanks for their 65,000 plus years of custodianship of the land we get to call home. Today is a special day. National Myeloma Month sees the global community come together to focus our attention on myeloma, to raise awareness, to educate, and to share experiences and knowledge. We are on the path to cure, and this is the focus that holds our global community together. We have a lot on our agenda today. I want to thank all of our speakers in advance for their time, and I look forward to their presentations. I'm now pleased to hand over to my wonderful colleague, myeloma support nurse and South Australian-based Jo Gardner.
Thanks very much, Mark, and to all our viewers, welcome. I am the support nurse for Myeloma Australia in South Australia, which is Ghana country. I'm excited to chair our first of 3 seminars today with my co-host, Megan McDowell, who's our Queensland myeloma support nurse. The theme of the 2023 National Myeloma Month is the multiple faces of myeloma. This theme reflects the indiscriminatory nature of myeloma and the individual and widely varied needs of our myeloma community. We've aimed to include something for everyone today in our content and look forward to answering lots of your questions through our chat function on your screen. We have our wonderful support nurse, Alicia Hopper, on the support line today, who's available for any technical support or questions that you might have. That number is 1800 693 566. And if you have a question that wasn't answered today, would you please email them to nurses@myeloma.org.au and we'll reply as soon as possible over the coming few days. Today's session will be recorded and will be available on our website for later viewing. We'd love to hear how you found today's seminar, so please take the time to tell us by using the evaluation button for week 1 at the bottom of this web page. So now it's my great pleasure to introduce Dr. Nick Webber. He's a clinical haematologist at the Royal Brisbane and Women's Hospital and senior clinical lecturer at the University of Queensland. Nick's a humble man and hates bios. So welcome, Nick. We are so looking forward to hearing your talk this morning about the doctor-patient relationship and getting the best outcome for you and your doctor from your clinic appointment. So thank you, Nick.
Thanks, Jo. And I just wanted to thank you and Mark and the team at Myeloma Australia for the excellent work you do and for inviting me today to speak. It's really nice to be able to speak on a topic like this, which is different from the kind of talks that I'm usually giving about myeloma. It's really, I think, a good opportunity to discuss some of the non-medical aspects of myeloma care and hopefully share some thoughts about how patients and carers can really get the most out of their interaction with their doctor. So I found it really interesting to reflect on this topic, and I've put together just a few slides to share some thoughts about what it means to share decision making. And I'm hoping then that we can use those to stimulate some discussion between you and I, and hopefully members of the audience that are listening in or watching can feel comfortable to chip in and add their thoughts and questions. So patient-centered care is a concept that has been discussed widely for many years in the health system. It's a philosophy rather than a rigid practice or clinical procedure. It's really describing a model of care that is putting the patient at the center of the healthcare team. So we talk about healthcare that is respectful of and responsive to the preferences, needs and values of patients and consumers. So there are multiple different aspects to how this looks in practice, and really some of the things that have been emphasised as being critical for patient-centred care is are listed there on my slide. So education of the patient and their family members and support people, and sharing of knowledge is very important to make patients feel informed about the decisions that they're making with respect to their care. Involving family and friends, and sometimes that's someone outside of the family group. It may be involving advocates, it may be involving interpreters, cultural support people, etc. Collaboration and team management, so really enlisting the help from multiple different members of the healthcare team, not just the hematologist and the nurse, but also other aspects of the system that can be of assistance. Sensitivity to non-medical and spiritual dimensions as well. So accommodating, respecting, and incorporating patients' beliefs about healthcare is very important. These might be alternative practices, complementary medicines. They may be spiritual or religious aspects that are important to the patient. And so these things should be considered and factored into a patient-centered care model. As always, respect for the patient's needs and preferences comes number one. And so in order for patients to be heard, clinicians, healthcare workers need to allow patients time to express those needs and preferences. And finally, the free flow and accessibility of information. And this is something that I think is becoming more possible with digital medicine and the ability to transfer information electronically. It's almost going the opposite way now, where we have a huge amount of information that's available online through various different sources, and it can actually be quite overwhelming for some patients looking at the amount of information that's out there. And so I think a patient-centered care model is also about healthcare providers helping patients put that information into context and interpret the information that they obtain through means outside of the clinic setting. So lots of nice concepts there, but as many of the audience will attest, clinic is a busy place and time is often short. So these things don't always get the attention that they deserve. And I think patient-centered care is an aspiration rather than a rigidly entrenched practice in a lot of hospitals and clinic settings around the country at the moment. Certainly, I think what I would emphasize is that any system should really make patients feel that they are in partnership with their doctor. The old model of doctor knows best, the paternalistic system of the generations before me is really a thing of the past. And we want patients to feel empowered, to have a voice and to be able to advocate for themselves. And so shared decision-making really is just that. It's shared between the patient and the doctor with support from nursing, allied health and other staff. It's not always easy though. And I think there are some things that are challenges to incorporating this kind of practice. The first thing that comes to mind is really the huge imbalance in knowledge and experience between the doctor and the patient. So myeloma, like many malignant diseases, is a very complicated beast. There's a lot of rapidly changing information and clinical evidence that is being published. And the doctor's job is to keep on top of all of that information and to distill that and interpret it for the patient's individual circumstances. Patients, on the other hand, may have never heard of myeloma until they're first diagnosed with the disease. And so really starting from a zero starting point. And so that huge imbalance in knowledge does put the patient at a disadvantage from the outset. And finding a common ground there in terms of education and sharing of information does take time. So I think that's where support agencies such as Myeloma Australia are so critical in helping patients to do their background research and to understand a bit more about myeloma, its pathology, its treatment, to help give patients a little bit more of a platform to form their own decisions and feel that they can start to make their decisions in an informed way. I mentioned before that time is a critical factor in the clinic, and so there's one doctor for many patients, whereas for each patient there's only one doctor. So competing demands for physician time is a factor that is very difficult to address, not only in the public system, in the private system as well. And so it really means that patients need to try and get the most bang for their buck out of the consultation time that they have with their doctors. And we'll talk a little bit later about how we can do that. And finally, at the system that we work in Australia, the model that we have of healthcare in Australia is resource limited. We don't have infinite funding and resourcing to provide the amount of support that maybe we would like to. And so we have to be mindful that there are restrictions on access and availability to treatment. And I think we all need to accept that we have an excellent healthcare system in this country, but it does have its limitations, and we need to try and work around those limitations rather than feel defeated by them. So just some thoughts about what can patients and carers do to participate in patient-centered care. Hopefully this is transmitting clearly on the screen. But 3 things: preparation, organisation, and being assertive. So preparation is important. As I mentioned, when we have small window of time to discuss things in the clinic, it's a good idea to write down questions in advance. It's surprising how infrequently people do this. I think we all assume that our memories are fine and we'll remember to ask questions, but without fail, people always remember what they wanted to ask 10 minutes after they leave the consultation room. So it's a very good idea to get into the habit of writing down, keeping a list on your mobile phone or a notebook in your bag, and just jotting down questions as they occur to you so you can ask them in advance. Ask them at your next consultation. Likewise, if you're having trouble with treatment, if you're having side effects or experiencing things that may be intermittent, maybe not happening every day, but when they do happen, it's a good idea to write them down so that you can remember them later. Being aware of what you're taking in terms of medications is critical. We really do a lot of medication counselling in clinic, and pharmacists are often crucial in this. But it's surprising how often I'll ask patients what they're taking and they really won't be able to tell me. They'll defer to a caregiver, or they'll assume that I know it all because it's all written down in front of me on the screen. But we make changes to medications all the time. And so keeping a printed list, annotating that list and asking for a refreshed list when things change is a great idea, and bringing that to every appointment. Seeking information from background sources before your appointment is a great idea. So doing some homework through Myeloma Australia, through other organisations that are reliable and presenting good quality information, then helps you to refine the concerns and questions you have to then discuss and seek clarification from your doctor in the consultation. Being organised is a similar concept to being prepared, but really is more around helping things run smoothly when you come into the clinic. So making sure that your blood tests are done in advance of your appointment, arriving on time to the appointment and making sure you know where to go. Often very helpful to bring a second person, a set of ears and eyes to help absorb information that you may not be able to absorb, and sometimes to help when information might be unexpected. If there's bad news or a change in plan, it's a good idea to have someone else in the room. And maybe if you don't have someone available in person, you could have someone on standby so that if you do need to enlist their help, you could perhaps call them and put them on speakerphone during the consultation with the doctor. And I'm sure all of your treating physicians would be very happy to have someone else on the phone, just listening, providing that second set of ears to hear what's going on. And then being prepared as you're leaving the clinic involves making sure you know when your next appointment is, making sure that you've got a list of your future treatment appointments, that you've checked them, that the times appear correct and that you'll be available to present on those days. Finally, being assertive as part of that partnership and that relationship with your doctor is important. So it's always a good idea to ask for help if you're unsure, if you're uncertain. Sooner you ask, the sooner it can be sorted out. And so tell staff if you're unsure. Tell the nurse that's giving you treatment or the myeloma support nurse that's seeing you in clinic. It does not hurt to ask, and there's no such thing as a silly question. I think people probably struggle a bit with the next point about making your wishes known and your preferences clear. I respect and understand the fact that a lot of patients may feel uncomfortable discussing personal issues or expressing preferences that may go against what's being recommended to you by the doctor at the time. I know a lot of patients in the past with me have only verbalized those concerns to other members of the healthcare team and seem to have been reluctant to share them with me directly. And I think that it's not a fault. It's often because people don't want to offend or don't want to appear to be ungrateful or difficult. But really what we're talking about is putting you at the center of the decision-making process. And if you don't speak up and tell us what you're thinking or what your wishes are, then you will feel a loss of control and feel ultimately unsatisfied with your care. And so if you do need more time to consider options or to seek a second opinion, then it's always a good idea to ask for more time. Just say, I don't feel 100% comfortable with the direction things are going. I'd like the opportunity to go away and come back in 2 weeks and perhaps discuss it further. And I think the only time that it may not be appropriate to do that is if there's clearly a medical reason not to delay treatment. And in that case, I would expect your doctor to communicate that and explain why that might not be appropriate. So on the other side of the coin, what can we as healthcare staff do to practice patient-centered care in the clinic? And I think the first point is critical. Information overload is a common problem, especially when patients are first diagnosed with myeloma. And so it's our obligation to provide succinct information, relevant information in digestible amounts. That may be in the form of written material, it may be recording a consultation, and perhaps following up with a phone call or another visit shortly after to help with further communication. We need to be able to allow patients time to ask questions and to seek clarification about things that they're not sure of. And this is where the system often produces impediments and restrictions on time. And getting around that and navigating that can be tricky, but it's always a good idea if we signpost early on that we have a lot to talk about, that we'll need to make a follow-up appointment to get through what needs to be discussed, and that there may be alternative strategies for doing that. So perhaps a telephone call at the end of a clinic rather than a face-to-face review, perhaps organising a family meeting with other members to come in at a certain time. And I think this is where support staff, nursing staff can be very helpful with organising those sorts of opportunities. And I think finally, what we really should be doing is, rather than telling patients what to do, we should be presenting options. And based on those options, it is an obligation, I think, for us to present what we would recommend, what we think is in the patient's best interests. And ideally, we would see the patient agreeing and both parties coming to a mutual decision. Sometimes patients may choose an alternative option from what the doctor's recommended. And as long as that's done in an informed way, that's completely appropriate. But I think what sometimes happens is patients are presented with options, but no clear recommendation or guidance from the doctor about which is the best. And I don't think that's very helpful for patients. I think patients should have options, but also they should be given a best option on the opinion of the hematologist. What we should avoid doing as healthcare staff is making assumptions about patients' wishes. And I think that often happens in oncology, where quality of life versus quantity of life becomes a balancing act that the patient may have different ideas and beliefs from the doctor. So making assumptions about what a patient would want based on what I would want as the doctor is not appropriate. Presenting a single option without even acknowledging that there are other alternative options to explore, I think is not in the spirit of patient-centered care. And disregarding patient concerns as being trivial or irrelevant, I think is also a big no-no. We don't want to make patients feel as though they're not being heard. And some concerns, whilst they may seem trivial to the doctor, may be hugely important for the patient or their family. So these are things that I believe we should be doing better as healthcare staff. So how does this look in practice? Well, myeloma treatment is an increasingly complex journey, particularly as patients move from the newly diagnosed into the relapse setting. And what's confusing, not only for patients, but also for myeloma specialists, is that there really is no single gold standard pathway to follow. There are multiple options. And more than any other blood cancer that I treat, myeloma requires true individualization. So what worked very well for some other patient may not actually be in the best interests of the patient in front of me. And choosing which approach to take at which time point is really a very nuanced decision. So I think that's a really critical thing for patients to understand, that there is no single right way to treat myeloma, particularly in relapse. As things change and the treatment options are increasingly expanding, we know that, excuse me, my printer's just woken up for some reason. We know that these decisions may need to be reviewed, and new evidence may emerge to suggest that perhaps we take a different course from what we'd originally planned. So it's very difficult to think 3 steps ahead. It's sometimes not in the best interest of the patient to think 3 steps ahead, because things are changing and new options may be available all the time. So I think for simplicity, it's best to keep things all about what's happening now. And in terms of what's coming in the future, we leave that for the time that it's necessary. In weighing up these decisions and making these decisions about treatment, there's lots of different aspects. And I've just presented here some questions that go through my mind when deciding about what treatment to offer a patient. And then what the patient might be thinking and what questions they're asking. And they're really very, very different questions. And so I'm thinking about the medical aspects of the treatment, the history and the characteristics of the disease behavior, what geographical or financial limitations may be placed on patients and how that might affect their treatment. Whereas patients may be thinking about, how is this going to make me feel? Is this going to stop me from doing things that I want to be doing? And if so, is it worth making that sacrifice? Is it going to pay off for me in the long run? Can I get extra help with managing this treatment? How do I tell the doctor that, you know, I'm not interested in further treatment and I'd rather pursue a palliative care approach? And so if we're not communicating and discussing these questions, we may very well arrive at very different outcomes and make very different decisions. And so being in partnership means bringing both of these sides of the table into a middle ground and working together, understanding where each party is coming from, to then move forward together and make decisions that we're comfortable in progressing with. And I think communication and mutual respect are really the 2 principles that are critical there to make sure that this all works nicely. So having said that then, Joe, that's all I wanted to say about what patient-centered care means to me, and I'd be very interested to hear your thoughts and any additional things that you observe from the clinic space about where this works, where this doesn't work, and how we can make it better.
Thanks so much, Nick. I agree with you. The clinic space is not ideal, but we all have to work within systems, and by understanding how those systems work, we can make them work best for us. That was a really good overview of your approach to patient-centered care, which is really the ideal, and I think you've outlined that really well. Unfortunately, on our support line, we do get lots of calls from people about how best to communicate with their doctor, or are being frustrated at not receiving the information that that they need to make those decisions. So we all know that people communicate in different ways as well, and there are different personalities, and not all personalities get on. But unfortunately, you sometimes just have to make the most of being able to deal with someone, and the strategies that you've outlined, I think, were really useful. So you did talk about the different priorities of the doctor and the patient, and it is quite common that people feel like they want to give up, that that it's becoming too much of a burden, and can I just let nature take its course? So how do you have that discussion, Nick, to maybe outline other treatment options and take those concerns into play?
It is a common question, Jo. It's different for everybody. As you say, some patients are very keen to push forward and will happily accept toxicity and burdensome treatments if they think it will give them some disease response and remission. Other patients have a very different approach and are really unwilling to accept any toxicity if they're feeling well or relatively well. It's a very individual choice. I think one of the things I come across often is fear about side effects, and often that's based on past experience with chemotherapy treatment. And patients may have had a line of therapy that resulted in side effects such as neuropathy, fevers, or hospital admissions because of infection. And therefore they become very reluctant to consider retreatment when their myeloma progresses, because they're afraid of having a similar experience to what they had the previous time around. And 9 times out of 10, what we offer at relapse is not what we offered the time before. And so when we move from, say, a Velcade approach to a Revlimid approach, the treatment is very different, and the spectrum of side effects can be very different as well. So I sometimes find myself having to challenge that fear and explain to patients that what we're giving you this time, or what I'm suggesting that we give you this time, is not what you had last time, and the side effects are not necessarily going to be as bad as they were, and may actually look very differently. And we don't know until we try. And I think overcoming that hesitation is the first aspect. The second aspect is if we do not treat, if we truly don't have any options that we think are going to be acceptable to you as the patient, that are going to have a tolerable side effect profile and are going to have a good chance of working, then I think it's entirely appropriate to adopt a supportive care approach, which is where we focus on symptom management and we maximize support to keep patients at home or wherever they wish to be while the disease takes its course. If we have options, however, that patients haven't tried that we think are likely to work and should have a manageable side effect profile, then it does become difficult for me as the doctor when patients say, I really don't want that. I don't want that because I don't want any side effects and I'm enjoying my quality of life as it is. And the reason it's difficult is because myeloma itself is a very unpleasant disease, or can be very distressing. And if we abandon therapy or stop therapy, we run the risk of the myeloma progressing and causing side effects and symptoms of its own. And so in that circumstance, treating with chemotherapy or some other form of therapy is really designed to try and prevent the myeloma from causing its own organ damage and its own symptoms. And so having to explain that, can be a little bit difficult. Myeloma is not a painless condition. It does have the potential to cause significant disruption to quality of life, significant pain, and untreated myeloma can progress for many months and make people really uncomfortable and miserable. So looking at it from that perspective then challenges that concept that if I do nothing, if I don't have treatment, my quality of life is going to be great. And, people, I think, don't really think through to the end result of that. That's kind of two things that come up frequently in those discussions with me. At the end of the day, I have, patients from time to time who have understood that say to me, yes, I hear what you're saying. I understand that in the future, my myeloma may make me sick, but I really don't want anything until that point, until I absolutely have to have treatment. That's when I'll do it. And whilst I might be uncomfortable leaving it till that late stage, I think I need to respect the patient's wishes in that case if I feel that they truly are informed about that.
So many things in myeloma come down to that equation of risk versus benefit, don't they?
Yeah.
Whether it be the risk of an impact or short-term impact on quality of life for long-term gain of disease control, or whether it be the risk of the side effects in later stage disease versus the risk of not treating that disease and the impact that would have on quality of life.
Yeah.
It seems like a lot of those discussions hang around that equation. One of the strategies, sorry.
And I think that's where it's important for patients to ask, is this likely to work? So what are the response rates like of the treatment that you're suggesting? And what is the toxicity profile? Do you think I can tolerate this treatment? And if the answer is there's a good chance that it will work and there's a good chance that you'll tolerate it, then I would be 100% in support of it. If it turns out that the treatment that's being suggested has a 20% success rate and a 90% chance of causing significant side effects, then that needs to be factored in, and the patient will then make the decision, okay, I don't like those odds, I think I'll pass. And I think asking for a bit more detail about what can be expected from the treatment is really important, rather than just blindly, accepting and taking the treatment as suggested.
And we do often explore those options in a little more detail on the support line. We never make recommendations for treatment, of course, but we can give the background to the side effects that may be expected, and look into some of the issues in regarding access and travel and the financial burden that might occur from that treatment. So as you say, these are all the things that need to be taken into consideration, and not just the pure myeloma itself. And one of the strategies we talk about on the support line in regards to symptom management is keeping a symptom diary to note when something started, and to check in maybe on a weekly basis as to whether that symptom has got worse or better. And that symptom diary will accumulate into a personal history of your disease, and help decide when a change of treatment is offered, and that you might be facing a new set of symptoms, or symptoms that you've dealt with before, and how you best manage them, and it's there in a record. So it's one of the strategies that we promote. As patients go through their myeloma journey, Nick, they often accumulate other medical conditions, or have brought other medical conditions to the diagnosis of myeloma, and end up seeing multiple specialists. So how do you all communicate so that the patient still stays central to this story, and everybody's aware of all the other prescriptions that people have have contributed to their medical management?
It can be an issue, and especially when that care is shared between community and hospital providers, and whether there may be private clinicians and public clinicians. In patients who are seen exclusively in the one hospital, it's very easy to share records, to see letters, to read clinic notes and know what's happening. But sometimes the GP is expected to be the central point of contact. The GP may be receiving correspondence from private physicians, from community services, from optometrists and podiatrists, and me in clinic, I don't receive that information necessarily. So I think keeping the GP actively engaged while you're having myeloma treatment is very important. I know that you're often seeing us here in the clinic once a week, and so it doesn't leave much time to go and see the GP. And often I find myself doing scripts for blood pressure tablets and diabetes tablets because I'm seeing the patient more frequently than their GP ever did. But I think it's a good idea once a month to make an appointment just to touch base with the GP. Let them know how you're going with your treatment. Let them know what's changed since the last visit, and give them an opportunity to stay engaged in your care, because things like blood pressure management, cholesterol, screening for other cancers like prostate cancer and bowel cancer, all of those things are still important to continue while you're going through myeloma treatment. And the GP, I think, is a critical person, and too often they get left out of the loop when patients become engaged with the hospital system. Other than that, I do think it is difficult in this system where there is segmentation of care. I try to encourage patients to bring results and copies of results to their appointment with me so that I can at least see what's going on with, say, the cardiologist or the kidney specialist. If necessary, we can pick up the phone, but time is always an issue. And so if patients can request copies of their results, bring them in person, or at least ask that those results be CC'd into us at the hospital, it does help to keep it all on file with us.
Thanks, Nick. You did mention earlier in your talk that it's quite common for patients to remember all those questions they wanted to ask 10 minutes after they've left the clinic. And you did talk about, writing those questions down in real time, whether you've got a list on the fridge or in the bathroom or somewhere where you have those thoughts pop into your head, and it's a good idea to do that. But if I have forgotten, can I call you back, or what's a good way to address those? Can I feed them through someone else in the system?
Yeah, I think it's a good idea, and most clinics should provide patients with a contact number for appointment inquiries. And it's a good idea to establish who's available to respond to those sorts of queries. So there may be a myeloma support nurse, there may be a cancer care coordinator, or it may be a nurse in the clinic section. If you can at least get a phone number, if you need to communicate something to me as the doctor that you think is important, that cannot wait till your next appointment, then it's good to speak to the clinic staff and ask them to pass on the message as an email or face-to-face, and ask to have your telephone call returned. So leave your phone number and ask for a call back. It may not be the same day, it may be 1 or 2 days later. And I can't guarantee that you will get a reply. If your question is not critical, it may get sort of forgotten or missed. So the best thing to do, though, I think, is to establish early on who you can direct your concerns to, and be mindful of the fact that some things can wait till the next appointment, and that urgent queries are the ones that really should be directed to the clinic staff, because of course they're always very busy as well.
Yes, I think it can be easy to get to stay focused on yourself and forget that this whole system is working around you, and that there are a lot of Nick, just one last question. When you have to give someone bad news, it must be really tough on you as well. You'll know in advance that the results are not what you've wanted to see, or the treatment's not working as well as you would have expected, or the patient is suffering side effects that are looking like you may have to change direction. How do you prepare for that and then ensure that that patient is supported during the receiving of that information?
How do I prepare myself for that?
There is an impact on you as well as the patient, obviously.
Yeah. Look, I think myeloma patients in general tend to be quite engaged, and because we have the paraprotein as a tumor marker in the majority of cases, most patients know what their numbers are doing and ask, and we have a month-by-month account of what's happening. So I do try to signpost early for patients if things are not going in the right direction. Generally speaking, we don't act on one result. We need to see a trend before we make a call about whether we need to change our tack or not. And so making sure that patients remain informed about their results and signposting early on if things are not heading in a good direction is what I try to do. And I find that most patients are interested to know that information, so that when we do have the discussion that, look, it looks as though the myeloma is no longer responding to this treatment, or it's time to start another line of treatment, at least there's some warning, and it lessens the shock somewhat. I think the hardest conversations are those when we're reaching the end of our available therapies and there may not be any suitable options left. And again, I think being prepared and thinking ahead of these things is really important. So I'll encourage patients to have at least considered what will happen in the worst case scenario, to make arrangements and to think about what they want for an end of life scenario, have those discussions with family and friends, make a will, make an advanced health directive, and then put it in the drawer and forget about it and focus on what are we going to do today to help this situation. And from there on, it's a day-by-day process. I don't think that approach works well for everybody. Some patients interpret that as me telling them that they're going to die in the next 3 months and it's all doom and gloom. But what I'm trying to do is prepare for that well in advance when patients are in a good frame of mind to be doing that, and to be thinking ahead when it looks as though we're running out of options and there may not be a lot of time ahead, making those end-of-life arrangements and then focusing on the day-to-day. And making sure that there's always something we can offer, whether it's chemotherapy, whether it's pain relief, whether it's transfusion support, or whether it's just a face-to-face chat. I think our job is to be there through all of those stages of the illness. I don't know if I've answered that well, but that's my reflection on a difficult subject.
It is a difficult subject, but I think that if you can guide patients through that early process of recognizing that there are important decisions to be made and that there is still a plan available, knowing that in advance, it can actually be a real comfort and relief, not only to the patient, but also their carers and their family, that yes, but here's the plan, here's the structure. So that then can help me go back to focus on the day-to-day needs, as you said, and put that in the top drawer. We've addressed that, and maybe at some stage in the future that's going to be needed, but not now, and there are still things to do. So it's a great approach, and thanks for outlining that, Nick.
You're welcome.
So with that, I think we don't have any further questions. And again, I'd really like to thank you, Nick, Dr. Weber. It's been an unusual and not an often broached subject for a consultant haematologist to talk about, but to hear from the other side of the desk, your experience of the clinic is really important for our community. So thank you so much, Nick, for your time today.
You're welcome. Thank you very much. Thanks for having me.
And with that, I'll throw back to, sorry, I think we're having a break. So we'll just go back to the central, oh, sorry. Oh my God, I've lost it. So we'll just take a break, please.
Hi, welcome back, everybody. Sorry for that technical difficulty. We were just shuffling a few slides, and we're happy to welcome our next speaker for our seminar today. My name's Megan McDowell. I'm a support nurse based in Queensland, and I'm very happy to be here today with you all. Chris Andrew is our next speaker, and he is an accredited exercise physiologist. He's got a master's degree in exercise oncology and has practiced clinically as an A&P for 10 years. He practices in regional Southwest Australia. He specialises in cancer management through exercise prescription, focusing on intervention with initial diagnosis right through to end-of-life care. Chris specialises in combating side effects associated with treatment and hoping to enhance quality of life while doing so. Additionally, Chris is a PhD student at ECU, exploring exercise implementation in rural and regional areas of Western Australia. So a big and amazing bio there, Chris. Welcome, and we can't wait to hear your experience today.
Great. Thanks, Megan. Thanks for the introduction. It's a bit of a mouthful, I'm sure. And I apologise to everyone. There's a bit of an echo in the office at the moment. It's not too full. But hopefully everyone can hear me okay. And please let me know if I'm doing anything wrong with the technology side, because that's not my biggest asset. But I appreciate the introduction. I'm very, very grateful for being here and presenting to everyone. So yeah, hopefully everything here makes sense. And please feel free to ask as many questions as you'd like afterwards, or get in contact through Megan or Joe or whoever else involved. So let's get started. So today I'm going to be talking about exercise medicine in oncology. It's using exercise to manage specifically fatigue in this circumstance. So as Megan said, I'm an exercise physiologist, which I'll explain what that is in a second if anyone hasn't heard. I have been practicing clinically for a number of years now in regional Australia, and completed some extra study for oncology specifically, which I specialise in now. And I'm currently doing an implementation project as a PhD student in delivering exercise or using exercise as a co-therapy through the cancer continuum. And I also work at Genesis Care using exercise as a medicine in the clinic in Mandurah. Okay. So an exercise physiologist, or an AEP, or a universally qualified allied health professional. And what we do is we use exercise to design, deliver, and evaluate safe and effective interventions for people with acute, subacute, or chronic medical conditions. So essentially, we use exercise as an intervention and a prescription to help with chronic disease. Does this change the way we manage cancer patients? Absolutely not. And does it mean we take a safer, gentler approach? Not necessarily. We'll talk about that through the slides today. And are we competent enough to prescribe exercise for all cancer types? Yes. So let's talk a little bit about exercise as a medicine, if only it was that easy. Essentially, we use exercise to do a lot of things, and in the cancer space, what we know is that we can help to improve surgical outcomes, we help to reduce symptom experience, manage side effects of radiation, chemotherapy, immunotherapy, and even surgery. We help to improve psychological health, help to maintain physical function, and reduce fat gain, bone mineral density loss, and muscle loss. So you can imagine a medicine or a medication that can do all of those things with very little side effects. It'd be very, very handy. And that's essentially what I'm talking about today. I think a lot of us would love it in a pill, but unfortunately it's not that easy. So let's talk about exercise in general. So when we look at exercise and the management of cancer, we know that cancer brings through a plethora of sections, whether it be diagnosis or pre-diagnosis, whether it be surgery and or treatment. Some common side effects, as you can see in the left of that fuzzy diagram, you can see we have increased fatigue, increased depression, anxiety, weight gain, cardiovascular disease, and just generally a decrease in function and quality of life. When we implement physical activity programs or prescribe an intervention appropriately, the benefits of this can be summed up quite simply on the right-hand side. So we have essentially, a mirrored reverse of what I've just mentioned. So a decrease in side effects and adverse events, a decrease in fatigue, depression and anxiety, an increase in quality of life, and an increase in overall survival. So I guess to simplify this is that we know when exercise is used appropriately and prescribed within the cancer continuum, we know that it can help improve muscle mass, strength and power. We know that it can improve in cardiovascular or cardiorespiratory fitness, helps to improve physical function in general and activities of daily living, helps to improve range of motion, it increases chemotherapy and treatment completion rates, reduces anxiety and depression, and of course reduces cancer-related fatigue, just to name a few. So it's quite a handy tool if you can see it from that perspective. This is, I put this in just as an example. So, over the past 5 to 10 years, we have gathered a lot more resources available for cancer patients, this being one of them. And not everyone may have seen this, but it kind of sums up, I guess, where we've come in research and what we can give to patients as a bit of a guide to exercise. Unfortunately, with these sorts of resources, why I'm here is that it does break it down quite well. And as you can see, you've got the what. So you've got, for overall health, you've got guidelines, the why, and we know that for people during and following cancer treatments, how it can be of benefit. And we've also got the how. But unfortunately, it's not specific enough for a patient. So in a lot of cases, and this is me speaking clinically, is that we might have someone come in and say, yes, I understand the outline or the guidelines that we have to stick to, but what does that involve? What is this exercise? What is moderate aerobic exercise? And we will talk about that in a little bit. So that's an important part of these resources, that it's a fantastic guide and there's a lot of them, but we just need to get into the nitty-gritty and really have an appropriate structure to have the most benefit. So again, apologies if these pictures aren't so good, but let's talk about the cancer treatments and side effects. I think a lot of patients and a lot of people can relate to some of these side effects seen on the left, and you can see the crossover. So whether it be chemo, radiation, surgery, hormone, immunotherapy, or targeted, you can see some common themes along each of those treatments. In particular, you can see at the bottom fatigue, and fatigue is something that we'll talk about in just a moment, but it is seen in a lot of cases through cancer treatment. And then it is important to look at exercise across all continuum, and this is when I keep talking about the continuum, this is what we look at as exercise professionals to the right-hand side, in that exercise is actually appropriate at all stages. It's never too late. It's not appropriate just after treatment. It's actually appropriate all the way through when it's appropriately prescribed by a professional. And the modality is important too. So whether it be pre-diagnosis, through treatment itself, all the way through to end-of-life care or palliation, it's important to know that exercise can fit in any of those areas and help with quality of life and all the other side effects I mentioned when appropriately prescribed. So let's talk a little bit about fatigue now. So we know that fatigue is often referred to as exhaustion, tiredness, lethargy. There's so many different ways that we can report what fatigue is, but at the same time, I've found just out of my experience that it's actually quite hard to report. It's quite hard to describe, and it's quite hard to sort of find similarities between people because it can be different in a lot of cases. So it's a result of mental, physical exertion and or illness. It's often got a close correlation between physical and mental factors. And when it's actually compared to fatigue experienced by healthy individuals or apparently healthy individuals, cancer-related fatigue is more severe, more distressing, and actually less likely to be relieved by rest, which makes it very, very difficult to manage. Cancer-related fatigue is often reported by patients as one of the most debilitating symptoms of their disease and treatment. And it's a distressing, persistent, subjective sense of physical and emotional and cognitive tiredness. So you can see it can be described in a lot of ways, but essentially it involves distress, a persistent sense of physical, emotional and cognitive tiredness through treatment before or even after. And it's not always proportional to recent activity. So breaking down fatigue further, you can see cancer-related fatigue has a lot of different arms and inputs, whether it be physical, psychological, biological, emotional, and social, a lot of different contributing factors. And over to the right, just looking at the causes of cancer-related fatigue, there's a lot of different things that are associated with cancer-related fatigue that can perhaps worsen it or can perhaps add to it, such as pain, anemia, lack of physical activity, all these types of things. And I'm sure a lot of people can relate to one, or if not a handful of these things. So again, it just contributes to the fact that cancer-related fatigue is quite hard to manage. So exercise, is it effective in this circumstance? These are my amazing pictures that I found. So hopefully it made a few people smile. Firstly, I think I'd like to spend a little bit of time on the little chart to the right, but let's just quickly talk about it from a research perspective. I'll try not to harp on this too much because I could talk forever. But when we look at fatigue and when we look at exercise, there is one particular meta-analysis or review of a lot of studies, 113, and there was almost 12,000 patients within these studies. And it was concluded that non-pharmaceutical interventions, specifically exercise, will help to actually improve cancer-related fatigue or reduce cancer-related fatigue, whereas the pharmaceutical interventions did not significantly improve cancer-related fatigue. Now, when we look at pharmaceuticals, it's often considered after ruling out other causes of fatigue, primarily used to help with pain, emotional stress, and anemia. So absolutely there is room for pharmaceutical treatment when needed, but there's little or empirical evidence for use with cancer patients, and use may be associated with the adverse side effects. When we look at non-pharmaceutical treatment for fatigue, let's talk about exercise. We know that it can facilitate changes such as increased strength, can help with energy and just general fitness, can help to decrease anxiety and depression, as talked about previously, and improve body image and functional tolerance. So it is known as a Category 1 recommendation for patients on active treatment or treatment completion. And it stresses the importance of appropriate prescription. So moving over to the right, you see a little bit of a dominoes effect almost of fatigue. So when we're fatigued, especially cancer-related fatigue, we know that we decrease physical activity in most cases. That will often lead to a deconditioning of the body, which can increase symptoms, for example, fatigue, so it can actually exacerbate fatigue. With that becomes a decreased motivation and perhaps behavioural changes, which then leads to a continuous decrease in physical activity. And when I say physical activity, it's important to know that that accounts for things like gardening, getting up and out of the house, going for a walk to letterbox. Any type of movement contributes as physical activity. So you can see with this constant circle, it can really be a detriment to the quality of life and just general health and someone's well-being. So the reason I have this chart here is that if we can somehow wedge this never-ending circle with something like exercise, we can really help stop this dominoes effect and hopefully perhaps flip it on its head and increase this physical activity appropriately, of course, and decrease the amount of deconditioning happening and decrease these symptoms and, of course, increase behavioural changes and just general motivation. So it's quite an important thing. And if I'm going to be honest, with a lot of patients, it doesn't happen overnight, but when we work with patients from an exercise perspective, it's just little and often to start and building up as a progressive kind of attack, rather than here's a bunch of exercise, go and do it. So this is what I mean by appropriate prescription. So moving on to prescribing exercise now in the treatment of cancer. So we talk about exercise, and when I mentioned this in previous slides with the resources, we talk about, okay, we understand the parameters and what we should be achieving, but how can we do this? Is there ways to modify? Is there wiggle room with this if we can't achieve 30 to 60 minutes per day? And what is involved with these types of exercises? So this is when I refer to modalities, this is what I'm talking about. Firstly, aerobic training. So aerobic exercise uses large muscle groups, causes your heart rate to rise during exercise. Very, very simple. And it makes strenuous tasks, or aims to make strenuous tasks, easier and can improve heart and lung fitness in general. So things like walking, jogging, cycling, swimming, skipping, climbing stairs, all of these rhythmic activities account for aerobic training. So when we talk about our recommend dosage, we talked about from the resources in particular, we want to achieve a moderate aerobic exercise, at least 150 to 300 minutes per week. It sounds a lot, but if we break that down, we look at sort of 30 to 60 minutes, 3 times a week of that, what we call moderate aerobic exercise. And a lot of people have asked me, okay, you say moderate exercise, what does that mean? What does vigorous exercise mean? So I guess the best way to describe this I've found, and I hope this sits with everyone okay, but if we're walking next to a person and we can have a general conversation with no stress whatsoever with the person next to us, we would count that as low intensity. Moderate intensity would be walking next to the same person, having a conversation, but having to stop, concentrating on our breathing a little bit, and having a little bit of intermittent stoppage in the conversation to the person to the right. When we talk about vigorous, that's walking next to the person and not caring one bit what they have to say, because all you're doing is concentrating on breathing and making sure that you can control your sweat and you're not willing to stop. So that's sort of how when I prescribe, I look at it. If we're looking for a moderate exercise, we can have a conversation with the person whilst we're completing the exercise, but it's a little bit harder and it's a little bit more concentrating on how we breathe. And going back to the recommended dosage, you've got, as I said, 150 to 300 minutes per week, roughly, or vigorous exercise, 75 to 150. Okay, and moving on to resistance training. So resistance exercise can include things like weights, resistance machines, and body weight. A resistance or weight training program can result in increased muscle function and strength, can help to improve body composition with increased muscle mass, can increase bone mineral density and muscle mass as previous. Sorry, there's a typo there. And then we talk about the recommended dosage here. So in a lot of cases, you're often, if you're not diving into the resources, you're often looking over 2 times a week is very effective for resistance training. And again, we look at 2 times a week. Okay, what does that mean? Sometimes we read resources that might say 2 sets of 8 to 15 repetitions, or 2 sets of 8 to 12 repetitions. But what does that exactly entail? How can we monitor that? And that's, I guess, why I'm here and why we have exercise professionals to prescribe the exercise, to really answer these questions and make sure it's the most effective without, other training principles such as, overload or burnout. And we look at flexibility training. So we know that stretching improves and maintains the flexibility and strength in joints and muscles. We know that joints and muscle flexibility is reduced in a lot of cases by some cancer treatments, and naturally as we get older as well, and by I should say decreased activity. And regular stretching helps to delay any reduction in flexibility, and it can help to overcome stiffness. So again, with this recommended dosage, how much do we do stretching? And there's not often a clear answer with flexibility. What I would say, and what research shows, is that more often than not is very, very good. Other things to probably mention in this slide that I haven't included are, what we call alternate interventions or alternate modes of exercise. And I'm talking about things like Tai Chi, yoga, Pilates, these types of exercise modalities. And what I would say is that absolutely include them if possible. There's no reason why these things shouldn't be used as a type of physical activity. because it's movement essentially. And things like yoga and Tai Chi, you've got that mindfulness aspect and the breathing aspect, which in normal modalities of exercise you don't emphasize as much. So for mindfulness, to reduce stress, anxiety, these are very, very important modalities of exercise as well. So I should mention that too. So don't have anyone argue with you and tell you that that's not good exercise whilst going through treatment or before or after. It's absolutely great physical activity. There's a bit of a delay there. Hope everyone can see that. So this is, again, my side, the research side. I've tried to find something that's not too doom and gloom, but again, we look at what's called there was a position statement released in 2019 through the Exercise and Sport Science Australia governing body. And this position statement went through, there was also one done previously in 2009, I believe, and that was, I guess, very broad in that, yes, we know exercise is good, and this is how much you should be doing, but it wasn't as specific as the latest position statement released. And I've taken this out. So it describes the type of side effect, for example, fatigue here, and what it is. And it tells us the most effective way of exercising to have the most effect on the actual side effect. Fatigue, multimodal exercise is the most effective. Aerobic is effective, a resistance is effective, and so is flexibility. But all of these put together and used throughout the week together is the most effective on cancer-related fatigue. And as you can see there, there's a strong body of evidence to support exercise as one of the most effective non-pharmacological treatments for cancer-related fatigue, and various exercise modes are effective in reducing fatigue. So a lot of proof coming out that an emphasis on putting these together can have the best effect for us. And how much is too much? And I thought I'd put this in here too. And this is what I look at as an exercise professional, and what any exercise professional would look at when delivering an exercise intervention to someone going through cancer. And this is how it's been defined and been of most benefit. So I would look at, firstly, a patient assessment. Then we look to determine or prioritise health issues. And that can be other chronic diseases too. Yes, you're going through treatment or cancer treatment, but you might have had a recent knee replacement. You might have high blood pressure. You might have diabetes. There are other chronic diseases that might be involved. And it's important to identify these and also prioritise and really set goals from here. Thirdly, we identify the patient's capacity and intervention suitability. All this means is that we have a look at the risk factors. We have a look at what opportunities we may have to exercise and where it might be most appropriate. Then we'll look at the actual prescription itself. So we look at, okay, what is the total exercise dose we'll need to have the most effect, depending on circumstances and also side effects. We look at what's called the FIT principle, or in this case, you've got mode, the intensity, the frequency and duration. So these are all characteristics of exercise programming. And most importantly, progression. Because often, like anyone, we see that we exercise and we have this stimulant and it's going really well, but we can tend to plateau, or we can have what's called a regression. So when we alter these training principles, such as mode, intensity, frequency, we can make sure that we can have consistent progression where see fit. We also look at the monitoring side, the education, and most importantly, the behavioural change. And lastly, we account for reassessment and modification. So this could be a change in treatment, a change in medication or dosage, a stoppage in treatment, weight loss or cachexia in these cases. Anything that may come up, it's important to reassess at that point and provide modifications. So it's important to know that we are practicing safely and we are accounting for everything that may happen throughout treatment. I put this in here. I thought it was quite important to know as well. It's quite intimidating going into starting exercise if you've never exercised before, or thinking about exercising when you're going through some really, really harsh treatment in a tough part of your life. And it's important to know that you're being looked after. So again, speaking from experience and what the research shows is that we use things to monitor. So for example, RPE, or a rate of perceived exertion, how much we exert ourselves. And we often look at this subjective chart to the right. And we want to be working to a certain extent, up until maybe 13 or 14. If we're in the 15 to 19 or even 20, we know that we have to reduce what we're doing so we can have some control. Otherwise, as you can see on the left, we don't have that linear progression. We have this up and down, and even looking at providing exercise during treatment, we have these days where we feel a lot better. So we think, okay, let's do as much as we can. And then, we have the days that we feel terrible and we do nothing, and we have this constant up and down. So if we can work with the patient or work with you and try and find that happy medium, let's say, this is where we can have some success and progress. And again, other considerations, I think it's important to know that when you're walking into a safe place, an exercise facility, or someone that's looking after you with exercise intervention, there are a lot of considerations that we make, and there are a lot of opportunities that can come from these. So other considerations could be other chronic diseases, injuries, other medical issues, or even treatment scheduling changes. But also the bigger ones, things like ostomies, presence of a urinary catheter in some cases, and even PICC lines or portacaths. With the inclusion of these, we can still provide exercise intervention because we know sort of what we have to consider and what we can use to facilitate exercise. So it's very important to know that just because you may have one of these things or other considerations such as injuries, doesn't mean you can't exercise. It just means you have to find an exercise professional to make sure they can help you, and you can have some benefits out of exercise rather than just throwing it off the table completely. So I thought it was a quite important thing to include. And finally, a couple of take-home messages. I hope I'm going okay for time, but I just wanted to sort of sum everything up in what I talked about today. We know that exercise now is a safe and effective form of cancer treatment when prescribed appropriately by an exercise professional. I would argue that close to 15 to 20 years ago, in a lot of cases, we were often shown to be told to rest. And that's because it's safe. And it's important to know that, progression of exercise has been incredibly successful over the past 15 to 20 years. And that is why we've shifted the focus to just rest, because we know how much it can exacerbate fatigue and other symptoms. Now we include exercise, and we know that it's safe and effective when done appropriately. Exercise should be considered a co-therapy at any stage along the cancer continuum. Again, I've talked about this cancer continuum from pre-diagnosis all the way through to end-of-life care, and exercise can be considered a co-therapy, or should be, along any part of that when prescribed appropriately. And to sum up everything, we look at Exercise as Medicine Australia, and they released this statement, which I found quite comforting, is that exercise plays an important role in the treatment of recovery from cancer, from diagnosis all the way through to end of life. And it's definitely not a one-size-fits-all. We know multiple exercise modalities suit different cancer side effects and treatment methods. The only way that we can be the most benefit or the most effective is that if we talk about this, we talk about our side effects and treatment methods. And in fact, a great way to do that, and this is taking a leaf out of Joe's book, who mentioned just earlier that a symptom diary is a very simple yet effective way to track this. When you're seeing an exercise professional or a doctor or anyone, if you have cloudiness from treatment, and all of a sudden you've got a diary that says, well, actually this day I felt like, you can pick up these patterns. And as an exercise professional, this can really help with how we deliver exercise and how we control. And in any case, exercise does not replace treatment. In fact, it will help optimize the treatment for cancer and improve quality of life, as well as actually combat and reduce the side effects such as cancer-related fatigue. So it's important to not cancel out treatment. I'm not here to say that. I'm here to say that exercise can be a very, very effective co-therapy when it comes to cancer treatment and cancer in general. And I believe that is all I have for you today. So thank you for listening. I hope the echo wasn't too bad. Please ask as many questions as you like. And again, I appreciate the opportunity to present to you today.
Thank you so much, Chris. That was really thorough, and it's always heartening for me, who has seen the cancer space shift from, like you mentioned, oh, you're sick, you should rest, to what we now know, this huge body of evidence proving that's actually not the right thing to do and can be the worst thing to do. Obviously rest is important, but moving your body has such a great and important effect on your cancer and your health in general. I know that you would get these questions a lot, but there are quite a few barriers to having this prescribed exercise and be able to do it safely and confidently. And we hope that some of the Medicare suggestions and reforms will support that. But can you talk a little bit on some of the financial barriers with exercise physiology and getting that specialised support for starting exercise?
Absolutely, it's a really good question, and in fact, one of the the biggest barriers, and being in regional rural Australia, I see a lot of the cost, costs and financial disparities, or financial burden, I should say, as a big barrier to exercise, and that that would happen all around the world, I imagine. And as exercise physiologists, and what I talk about to patients is that there are a few opportunities or options for us. For in particular Medicare, we know that we've got the CDMPs, or the chronic disease management plans. They're not massive, but it accounts for 5 sessions per calendar year, which can take some of that financial burden off. And often there is a gap with the payments for exercise physiology. In some cases, it can be billed, but I encourage anyone that we're all, if you've had cancer or any chronic disease or illness, you're eligible for these 5 sessions per calendar year. So I would encourage everyone to see their GP to get these. Other than that, we also have private health. So exercise physiology is covered by private health. Checking with your provider if you do have private health to see if you're covered for exercise physiology. We often are. I think the only one we have trouble with at the moment is HBF, because we lie under a different category in that umbrella. So again, it's worth checking with your provider if you are covered by exercise physiology. Department of Veteran Affairs, again, that's covered with exercise physiology. And look, I think it's important to know that from a resource perspective, if the financial burden is something that is stopping us from exercise, we can really identify these resources and have a bit of a structure to stick to provide opportunity to exercise. This can be gym-based, home-based even, community-based. You've got programs such as the Life Now at the Cancer Council that's free. You've got other initiatives that do pop up here and there that are free. It's just a matter of trying to find these, and that's why we use people like yourself and other even not-for-profit organisations that can maybe provide a bit of a direction, or almost like a triage to certain programs that are available that are in many cases free or have a smaller cost.
Yeah. The free exercise programs that often run by councils are amazing, and we often refer people to those. And yeah, you mentioned the chronic disease management plan. So just to reiterate for people that haven't heard of that before, this is an allied health support program that is available through your GP, because myeloma is considered a chronic disease, and most cancers are. You're eligible for this chronic disease management plan, which you're allowed 5 allied health appointments. And because even the government recognised the importance of exercise physiology, that's included as one of those modalities. So I encourage all newly diagnosed people to seek out that plan and get what you're entitled to. My last question is going to fit nicely, because we're about to go into a break, and another barrier for someone that is feeling completely exhausted and may have never ever in their life done a formal exercise session or anything remotely close other than their incidental activities of daily living. As we're sitting here and our desks or at home on our phones or laptops, can you think of ways that our members watching today can weave in a little bit of gentle, either seated or standing movement that they can add in just at moments of the day when they feel like, oh, I just need to shift my body a bit, that you could recommend for our viewers today?
Absolutely, it's a great thing to get, and you can very much overcomplicate this. And I think getting up and moving, and something is better than nothing, as cliche as that is. There's ways to break that down, and I talk about achieving this 30 to 60 minutes 3 times a week, and it can be quite intimidating, as is a lot of other modes of exercise. But if we can break it down, if we can look at it intermittently and think, okay, if I'm watching a show and there's ads every couple of minutes, let's do something whilst we have those ads. or let's do something at the end of every hour or two, or when we get up from a nap, or even beforehand. And we can do things very simple. We probably break it down to 3 things. One being a walk, and either a walk outside around your house, a walk to the backyard, a walk, with a dog if you have one, and you can break it down to 5, 10, 15 minutes maximum. There's no real limit there because we're doing it a couple of times a day. That could be one option. Second one, and this is again during the adverts, let's get up and let's simply stand up and then sit back down. Call it a sit to stand. So we're just getting up and we're going back down. And let's do repetitions. Let's aim for 10, or let's aim for 6. And if we can do 6 to 10, then maybe after the next break, we do another 6 to 10. And then the next break, we do another 6 to 10. All of a sudden, you're doing 30 up and downs. And that, if we look at that for our, our structure for resistance exercise, we are looking for 2 or 3 sets of 6 to 10. So we're already doing that, and it's simple as that. And the last thing, let's include the upper body. Let's go against the wall that you have in your house, and let's just go up and down like a push-up against the wall, standing up. Let's do that 6 to 10 times. So all of a sudden, you're doing some push-ups, some up and downs, and you're going for a walk, and that's absolutely plenty. It's simple. You don't need equipment for it. It's during the adverts of whatever you might be watching, or it's towards the end or before or after a nap. And if you're doing that a couple of times a day, just a couple of times, you're clearly achieving that 30 minutes per day, which in total is absolute maximum. So it can be broken down to as simple as that, and it doesn't need to be done all in one go. It can be done in little bits throughout the day.
Those are fabulous little get you started exercise, and I want to thank you for joining us today. It was really informative. We love evidence, and we love evidence-based practice here at Myeloma Australia, so that's always welcomed by our community to know that we're not making this stuff up. Especially as an exercise physiologist, you probably get that a lot. Are you sure I have to do this extra push against the wall today, Chris? And to have that, all of that evidence behind you, makes it easier to be the baddie.
It does. The proof's in the pudding, essentially, and it doesn't need to be intimidating. It can be introduced slowly, and as long as it's done by the right people, it's just got mountains of benefit. It doesn't need to be intimidating as it would be on paper.
We should clarify that before starting any new exercise program, it's important to check with your treating medical team that it's safe to do so. And if you have been cleared for some gentle movement, we are about to take a 5-minute break. So I would encourage you, if you feel safe and you've got somebody at home with you, to try some of those seating, standing movements that Chris spoke about. If it's only 1 or 2, that's great. But if you can get to 6 or 10, put it in your chat book to tell us how much you did. We'd love to hear it. Thanks again, Chris. And we hope to hear from you with your experience with myeloma patients where you're working. Thanks.
Great. Thanks so much for having me, guys. I hope you got something out of it. Appreciate the invite for today. It's a fantastic initiative.
You're very welcome. And we're going to throw to a break now. Thanks, viewers.
everybody. I hope your bladders are empty and your cups are full for the next session. This session's entitled Navigating the System and Practical Assistance. It's really focused on the carer and who is a carer. And with that, I'd like to welcome really warmly Jo Dobson from the Carer Gateway Services in Tasmania. Welcome, Jo, and thank you for stepping in at the last minute. We really appreciate that support from you. Carer Gateway is an Australian government initiative that provides free support to family and friend carers across Australia who provide unpaid care and emotional support to someone with a disability, mental ill health, alcohol or drug dependent, or who is frail or aged or has a terminal life-limiting condition. Through Carer Gateway, carers can access a range of free services such as counselling and coaching, get advice and referrals, and help with navigating the maze of supports to find services provided through federal, state and local government and non-government providers. So earlier we heard about the restrictions that actually going to see your doctor in the clinic provides, the system that they work under. Now we're going to look at the broader system behind what supports your medical care. So thank you so much, Jo, and I'll hand over to you.
Thank you. Thanks, Jo. Hello, everyone. My name is Jo also. I work here at Carer Gateway in Hobart, and I've been given the opportunity to talk to you about who cares for the carers and to give you some information about Carer Gateway, which is around Australia. So without further ado, we shall move on. And I've got a couple of campaigns that have run recently from Gateway to basically talk about who is a carer and help people identify so that they can get support. So I'll start that now.
There's almost nothing you won't do caring for a loved one. You'll learn paraparesis and other difficult words. You'll celebrate every victory and keep the most unsociable hours. So it's funny, the one thing you probably won't do is ask for help. If you look after a loved one, Carer Gateway is a free support service, especially for you. Authorised by the Australian Government, Canberra.
Not to over-egg the point, I've got another one we just want to show you that came out last year. And this one is really focused on the fact that carers wear many hats and do many things and could be anyone. So I'll get on with that.
Carers in Tasmania can receive all kinds of help through the Carer Gateway.
I was able to access specialist counselling.
I got some help at home so I could take a break.
I was able to connect with other young carers just like me.
I got help to navigate the maze of services.
If you wear a carer's hat, contact Carer Gateway for support with what you need in your caring role. Call 1800 422 737 or visit carergateway.gov.au.
Okay. So you may have seen a couple of those. I'm not quite sure if people are in Tasmania. They might have seen that and they might even know who those people are. So those campaigns were really effective and I believe that we had quite a good response and were able to help a lot of people out with their caring role. And I will get to that definitely at the end of this. How can we support carers? But first, I just want to talk about who carers are and what kinds of support, how do we identify carers? So the Commonwealth and the states have different definitions, not that different, but there is a slight difference in that the state definition is pretty much a person who provides non-contracted work and in an unpaid capacity. They provide ongoing care or assistance to another person, and meaning friend, relative, somebody they've met, the next door neighbour. The Commonwealth statement about carers talks about people providing personal care, support and assistance. They don't sort of mention the non-paid capacity. So there's a slight difference there, and sometimes that makes a difference when you're filling out forms, particularly medical forms when you're trying to say, I am a carer, but you might be doing everything except personal care. So as you can see, a carer is a person who provides the unpaid care and support to a family member or friend in these cohorts of people. So the person they care for is frail, aged, or someone who has a disability, and that includes people who may have a relative or a child with a disability and they have an NDIS package. That does not mean that we cannot provide support for the carer. The carer is our client, not the person they care for. So even people who care for someone who's frail aged who have a home care package, we can still provide support to the carer. We support carers who care for people with mental ill health, with alcohol or drug dependence, and chronic or terminal illness. So they're the cohorts of people we identify mostly as carers. There are a couple more cohorts that we have added just because it helps us to identify what kind of supports we need, and it helps our representation and advocacy for carers to government, because we want to constantly improve conditions for carers. So having said that, the next slide is about what are those conditions. Okay, so here's a few statistics just to help you. Hopefully you'll stay awake through this, because we'll get to the good bit after this. Sorry, but I think it's really important to know that actually 2.65 million people provided informal care in 2020. So Deloitte Access Economics did a survey in 2020, and this is what they found. This is the profile of carers nationally. 2.65 million Australians, which is about 10%, I think, of the population. 856,000 Australians are primary carers. Most care for a person with a disability. Primary carers just meaning they do the most care. I mean, there can be other carers that we recognise. So families could have two people caring for a person, so we call them co-carers. There could be people caring for each other, couple carers, and people who don't have a carer at all but need some respite, and we use the term self-carers. More than 2/3 of primary carers was found they were female. That's probably not a huge surprise, but I guess 2/3 are female and 1/3 would be male. Almost all primary carers cared for a family member. And that's an interesting statistic just in terms of identifying as a carer. I've spoken to lots of carers who say, look, that's my wife or that's my husband. I'm not their carer, I'm their wife. But actually, when you're thinking about caring for people with a disability or a terminal illness or frail aged, you are doing things that are a little bit different from what other people might do. So 272,000 carers were under 25 years old, which is about 1 in 10. I would say that probably identifying young carers, which are people under 25, is probably one of the most difficult things to do. The youngest carer is registered with us is 11 years old. And we have a dedicated young carer support worker who goes to schools and does all sorts of things like whitewater rafting and doing tobogganing or whatever people do, and have events for young carers so they can get together and have a chat with each other. The average age of a primary carer was 55 years old. And 55% of primary carers provided care for about 20 hours a week. So half of our carers are doing a permanent part-time role, really. So having said the youngest carer registered with us is 11, I think the eldest we have on the books who's been caring the longest, which I think is 20 years, is 79 years old. Okay. So that's a bit of a snapshot of in 2020. It may have changed slightly since then, but that's the snapshot of 2020. Okay. Anyone, anytime can become a carer. So not only can become a carer, but probably is a carer. Identification as a carer often comes after a health emergency and is very often not self-identified. So I hear the phrase many times, as I said, that's just, I'm not a carer, that's my husband or my wife or my child. And sometimes they're quite surprised that they are a carer. Young people do not identify unless the person they care for is palliative. So they don't, if you can imagine, going to a classroom and saying, do we have any carers in the room? They don't self-identify. But if the person they care for is palliative, they are more likely to identify as a carer and more likely to need mental health supports, especially if their parent has a life-limiting illness. In Tasmania, it is complex, and I'm sure it's complex everywhere. We have higher levels of chronic illness compared to the mainland, and we have a small population. We also have, and I'm sure other areas have this too, I hear it all the time, we have fly-in, fly-out specialists, because Tasmania is mainly a regional state. So that's how that works. It is not unusual for people to have to go to the mainland for treatment. And it is not unusual for carers to have to come home and to care for the person that they love or their family member. And I'll talk about that a bit later. But I just want to sort of give you a brief of, a call I just had the other day. So a fairly typical call. There was a social worker at the Burnie Hospital, and the social worker was calling to say, I have someone with a terminal illness and they have a carer, and I'd like to register the carer, knowing that when that person's discharged, there was few supports available for the patient. So the patient had a son, and he came over especially to care for mum because she just got a diagnosis of terminal illness. She was discharged with post-hospital support, so it was just personal care twice a week. And there was a little, and possibly in the works coming up was some support with domestic housework and in-home respite. Her son is 54. He is the only support for his mum, and he came from interstate. So he gave up his job and whatever he was doing to just come and care for her. He was unsure about how long she would live because the cancer is aggressive. And of course, PALCare provided support for pain and symptom management. The OT department, the occupational therapist did their bit. The aged care assessment team are coming in to do their bit, but all of these things take time, as we know. So the carer himself has a bowel condition that requires a colostomy bag, but he will not action this right now because he's looking after his mum. And the stress actually makes his condition worse. So there's quite a lot going on for him, and there's it's a complicated picture. Yeah. Okay. So he does not have a GP for himself yet. He's come over to care for his mum. He's got this complex condition. He can't get a GP for himself. and I don't know when that's going to happen. He actually helps his mum to the loo. He helps her eat, and he works on issues with her like reducing her nausea and how that's going to happen. The formal supports that are in place right now are just 1 hour twice a week, so he does all the rest. Overall, his statement is that he's focused on doing the right thing and he wants to give back to his mum as she cared for him as a child. And in his words, his goal is to give his mum the best care for her final days. So 1 in 6 Tasmanians are carers, and he is one of those. So you have probably, look, I'm going to say you may be a carer, you may have a carer, you may be very familiar with this. You've probably, if none of this is familiar, you will have seen people at the pharmacy or the supermarket or the waiting room at the GP, or even in emergency with somebody. And we'd like to see a world where those people are identified and asked for information, asked about themselves and included. We see them buying things at the pharmacy not for themselves, or updating scripts, or sitting with someone in ED, doing all sorts of things. So it's, how long is a piece of string? I'm sure that the person sitting not even next to you, but even the next person, is probably also a carer. Okay. So this is our campaign about the hat, which was making the point, which I'm sure you all picked up, that carers rarely identify as a carer. A lot of people we talk to say that they are already getting a Centrelink payment, or they're getting the pension, or as I said before, some other package, and they say, well, I can't get anything from Carer Gateway. So I'm just here to say that that has no effect on the services or supports you can get from Gateway, whether you have other Commonwealth funded supports or packages. Has no bearing. And in fact, we try to help those packages out. So sometimes, and often, those packages from other agencies like Aged Care don't provide the amount of support you might need. So we try to top that up. We have some short-term support we can put in place, and I will get to that. Okay. So let's just talk about, for a minute, sorry to hit you with some more numbers, but how about if we had to replace the carers of Australia? Well, we'd have to find 2.2 billion hours of unpaid care each year. That adds up to about $77.9 billion per year, and that's family carers. So that actually isn't even all carers, and that's 3.8% of our GDP, or gross domestic product. So each day, family carers contribute $213 million equivalent value to the economy. And just for us normal people, we can't envision what $1 million or $1 billion is. It's about $36 per carer per hour. So it's about $36 an hour. 44% of carers live in the lowest 2 quintiles of household income versus 34% of the general population. So there are 10% more carers living in poverty or below the poverty line. On average, Tasmanian carers earn approximately $69 less per week versus non-carers, and they participate less in the labour force by about 8%. And that's, again, for Tasmanian carers, but it's probably national, it's probably reflected nationally. And, you know, there are good reasons for that. which, as you're probably thinking right now, well, what does that do to our super as a carer? This is the impact. So this is the key findings from Carers Australia's Caring Costs Us. So there was another survey by Carers Australia, who are the peak representative body to government for carers. They did this in 2022. And they came out with these key findings. Australian carers lose a considerable amount of lifetime earnings and superannuation lifetime earnings in their caring role. The age a person becomes a carer is significant on the financial impact of caring. So that's fairly straightforward, I would say. Income support through carer payment is less than 30% of average weekly earnings. You may already know what the carer payment is. I think it's around the same as the disability support pension. Okay, so I'm not going to dwell on numbers anymore for you. I would like to get to some other facts. So we know that carers are often feeling invisible. They are not included in conversations at the GP or when people are registering with My Aged Care. It's not a question on the checklist. It's simply not there. So we are working at peak representation to change that and have that as a question. Do you have a carer? I'm just moving on, and I want to get to the bit where you get services. Okay, so there's a wellbeing impact, as you can well imagine, on carers. Let's just say we know that there's financial stress. Half of carers feel socially isolated. In our survey, there were 691 respondents, and our typical respondent was a woman in her 70s. So there was 1 in 3 had very high levels of psychological distress. So that brings me to our services. We try to identify, this is our structure basically, identify carers. We certainly empathise and ask how they are. We sometimes check if they need help managing medication, but we also check if they need help managing a lot of other things. Okay, so that's how are they going at home? How are they going with how they feel? Do they ever get time for themselves? What is the home like? And we really try to get down and identify those needs. Okay, so here we are. The gateway is national, as I've said. All our supports and services are free. There's no co-payments with that. There is one single number. That's the most important bit of information. So in your state where you are, if you call that number, that will take you to your local carer gateway in your state. If you're in Tassie, that will bring you to our office. If you're in Queensland, that will take you to another office. And of course, there's multiple ways to access the carer gateway. So it first came around in 2015, and about 5 years down the track, they opened carer gateways nationally. Okay. What do? Okay, so one of our most used services is the counselling. So we have counsellors. Every carer gateway has counsellors. You can talk to them on the phone. You can do Zoom. They do outreach. We have one counsellor that's in Burnie and outreach to Devonport. We go from here to Huonville, and we have another counsellor in Launceston. We have coaching, which is about reaching goals and support to reach goals. We have connection, where we run carer retreats. They are free. They are 3 nights and 4 days away, and we can support the person they care for while they're on a retreat. And we try to help navigate the maze of support. So My Aged Care, NDIS, Centrelink, they're our 3 biggies that we try to help people navigate. We have, I'll start with the planned respite and the in-home package of support and one-off support. So there's 2 kinds of in-home support we can do. They're very short term. Again, they are to top up the kinds of supports you already might have, or to help you get those while you're waiting. So if you can imagine, we might go in and do some domestic assistance while you're waiting for your home care package. So that's something that we offer all carers. We do all the residential respite bookings in the state with the residential aged care facilities, and we have a 24-hour line, so we have after hours, and if someone goes to hospital and they have someone at home they're looking after, we can put in supports for that person. This is a podcast series that we did, which is Carer Stories. So we've got number 1 is Catherine from Smithton, and Keelan is at number 4. He's 20 and he's a young carer for his father with mental ill health. We've got Kay at number 5, who's a great scone cooker, and she's in her late 80s and cares for her husband with Alzheimer's. Isabella is a young carer. She's 16 in Burnie. She's Tasmanian Aboriginal background, and she started caring at 8 years old. She cares for her young brother with autism, and her mum has MS. Ollie, number 9, is a non-binary young carer who cares for their partner and mother. So there's a podcast you can listen for free if you go to our website at Care to Serve, and they're very nice, interesting stories that people tell about themselves and their caring role. Okay, I'm sorry I whizzed through that last bit. You may have questions. Please ask away.
Thank you, Joey. Thank you very much. I'm sorry, but we are quite short on time now. But I think the key take-home message is there is one number to ring, and it will get you to your local carers gateway support service, and that there are lots of services available. And also, the one thing I've learned today is that if you don't have anyone looking after you, if you are on your own, you can still identify as a self-carer and get help and support from your service. So thank you so much, Joe, for coming along today.
Pleasure.
And now I'd like to hand over back to Megan in Queensland to introduce our final speaker today. Thank you very much.
Thanks, Joe and Joe, the double Joes. That was a wonderful, informative talk, and I'm sure a lot of our viewers will identify with some of the themes Joe touched on there. Today, I think ties in quite nicely with supporting our patients and our carers. I'd like to introduce Bruno Maraca, who is the CEO of the AFRM Claims Advocacy. Bruno is passionate about advocating for others. He's got over 20 years of experience in the financial service industry and recently established AFRM Claims Advocacy to support patients to balance their physical, emotional and financial well-being. Today, Bruno will be discussing how a personal insurance claim can support those within the myeloma community. Thanks, Bruno.
Thank you, Megan. First of all, thank you for the opportunity to be introduced to the Myeloma Australia community. We've recently partnered with Myeloma Australia, and it's very evident how passionate the team is in relation to making a difference, and we would love to be able to contribute to that. As was touched on, what I'm speaking to today really is about personal insurance. Personal insurance is insurance that is available to those who are injured or ill, and it may or may not apply to those in the audience today, but it might be some information just the same. So I'll go over to the slides. So just bear with me for a sec. Sorry, is someone moving the slides on, or? Yep, here we are. So our purpose is essentially to, our purpose being AFRM Claims Advocacy's purpose is really to improve the well-being of patients, and therefore reduce their financial stress. We recognise when someone is injured or ill, often it impacts their both their physical and emotional well-being, but also their financial well-being. Sometimes they're not able to work, whether it be at all or for a short period of time, and that can place financial stress. So we look to alleviate that financial stress, and how we do that is mainly through that process of exploring the personal insurance. I don't seem to have the clicker on the screen, sorry. Apologies for the technical piece. We'll certainly get there. Just a moment. I just want to make this screen a bit bigger. So what is personal insurance? So essentially personal insurance is, its intent is to support those who are injured or ill. It's often purchased directly, so people who have purchased it through their financial advisor, for example, or second to that, it may in fact be default insurance, what we call default insurance within a super fund. Now, not many people know that they have personal insurance in a super fund. In actual fact, and I'll touch on this later, but the research suggests that less than 40% of people are aware. But there is personal insurance in your super fund, and we'll cover that off in detail shortly. And the theme about that also is that if you do put a claim in for your personal insurance, it does not impact your super balance. So they are totally separate, although the insurance may be found within your super fund. So the 4 types of insurance, we have income protection, TPD or total and permanent disability, trauma cover, and death cover. So I'll just touch on each of these. So income protection is there to replace your income if you're not able to work, and it often replaces about up to 75% of your income before your injury. Total and permanent disability cover, or TPD, is a lump sum benefit if you're not able to ever work again. Trauma cover is there to be paid to the policy owner as a lump sum benefit upon a significant diagnosis like cancer, stroke, etc. And death benefit is essentially paid to the beneficiary upon the death of the policy owner. The themes around those personal insurance, and you may have heard of some or all of those perhaps, but the theme there is that, as I said earlier, not many people are aware that they have income protection and TPD and death benefits within their super fund. Less than 40%, in fact, the industry research will show. And the other thing that ASIC has identified is something what they call claim fatigue. What they mean by claim fatigue is that often when people aren't at their best because they are injured or ill, it becomes really challenging to go through the process on their own. And within the first 60 days, 50% of people have actually just given up on going through the TPD process on their own, because it can be quite arduous, can be quite difficult because you're not at your best and there's a few forms to fill in, as you can imagine. What we do, AFRM Claims Advocacy, recognising that the awareness is quite low, recognising that there's claim fatigue, we're here to help those who get injured or ill. So for the myeloma community, the first step of what we do is we check eligibility. So we check those who are interested in finding out about it, we check their eligibility and whether they in fact have cover or not. So that's the first step. That entails looking at your medical details and looking at your insurance policy, and then being able to come back and say, hey, you do have cover, you have income protection and TPD or what have you, or unfortunately you don't have cover and these are the reasons for it. So the eligibility check's a really good start. Second to that, let's assume there is a claim. If there is a claim, then the way in which we handle the claim is basically we act on behalf of the client. So we speak to the insurer so we can have the client focus on their well-being. We often realise when someone's injured or ill, there's a lot of medical appointments and a lot of downtime. So we don't want to burden them with the administration of the claim. We'll obtain the relevant claim forms. We'll help complete the claim forms. We'll lodge the claim forms with the insurer. We'll keep in contact with the insurer right throughout the claim process. And whilst all this is happening, we're keeping the client up to date so that they can focus on their well-being, knowing that we're looking after their claim.
Next slide there. Great.
Thank you. So the types of claims, I touched on the eligibility is free, but the three basic, I won't use the word basic because that's one of our claim types, but the three types of claims that we have are basic, intermediate, and complex claims. A basic claim is, for example, an income protection claim. The average income protection claim there is on $52,000. An intermediate claim, I'm not sure if you can see that too well. Actually, I just noticed, Megan, you're sort of reaching in there. Intermediate claim is a trauma claim. The average there is just on $200,000. And a complex claim is a TPD claim, which is the average balance is just on $260,000. So on those themes, as I mentioned earlier, our eligibility check for those within the myeloma community is free. We are a flat fee for service business. So what that means is that we have a flat fee regardless of your balance within any of those types of claims. And our basic fee is $2,800. Our intermediate fee is $3,875. And for a complex claim, it's $6,000. So that's how our three claims process occur. And the types that we have. Over to the next slide. Thank you. So in partnering with Myeloma Australia, we've sought to start the process to inform the community because, as we said earlier, the awareness often is quite low. And even if the awareness isn't quite low, often when someone's diagnosed with myeloma or any condition for that matter, it's probably not something that's top of mind. So this might act as a reminder for those to go back to their advisor or their accountant, etc., and get some support. But we're looking to inform the community through newsletters, the nursing team and the telephone support line, a website, and we've also created a dedicated website, which I'll take you through a couple of the pages of what that looks like. But you can see both a telephone address and an email address there on the screen. If you require our support, and we certainly are available to do that as well. So over to the next screen, thanks. So this is the dedicated myeloma and AFRM claims advocacy webpage. I'm hoping that most people can see the screen a lot larger than I can at the moment, but I'll leave you with the address at the end so that you can look at this in detail. But essentially the first part is, it talks about if myeloma has impacted your capacity to work, then this is how personal insurance could support you. Next page, thanks. It talks a bit about the types of personal insurance, which we touched on earlier, income protection, TPD policies, but both of which would be available to those who have cover and have myeloma. And then a bit about the process itself. Next screen, thanks. So the process itself and our contact details. I've raced through that quite quickly, and apologies for that, but I've just given you just a bit of a flavour. That web page is available all the time for those within the myeloma community to review, and there's a free eligibility check. And if anyone has any questions, they're certainly welcome to ask the team. Next slide, thanks. Yep. So just in terms of some themes around personal insurance, a sort of a did you know? Personal insurance is there, and its intent is to help people who are injured or ill. You are paying for it. So while you're making contributions into your super fund, or are making contributions into your super fund, a portion of that goes towards the personal insurance. It's just the insurers aren't big on telling anyone about it, and that's why we're doing what we're doing, and we're trying to create that awareness. It doesn't impact your super balance. It doesn't matter if you're diagnosed today or if you were diagnosed 10 years ago, it really doesn't matter. As long as you have an active super fund at the time, then it can be claimed retrospectively as well. One of the questions we often get asked is, look, I've got NDIS or I've got another compensation benefit. Does that mean I can't claim? No, not at all. It is policy dependent. However, often policies can work in conjunction with each other. So it's certainly worth exploring. And the other one I often get asked, which probably haven't put on here, but is it the same as private health insurance? Or how does my private health insurance complement this? So private health insurance, Bupa, Medibank, all those, if you have private health insurance or you don't, it doesn't matter. This is completely different, completely separate. Often the private health insurance is helping with medical expenses. This is here to replace your income, if you like, if you don't have the capacity to work or are diagnosed with something like myeloma. Next screen, thanks. So look, AFRM claims advocacy. We are supported by the Australian Patients Association. The Australian Patients Association are I suppose the voice of the patient. They're a not-for-profit group, and they do acknowledge and value what we do with not only the myeloma community, but others. They recognise our strong governance, our strong approach to making a difference and helping people, and that's why they are of support of what we do. We've been fortunate enough to connect in with a few other groups as well as Myeloma Australia, and you can see some of the brands there. And again, the theme's the same. Let's inform and educate the communities. So if we can help alleviate some financial stress, that's terrific. It might be enough that this information we provides you a trigger to go and seek assistance from support that you may already have. And if not, we will certainly be available to help you as well. Next slide, thanks. And look, that's just our contact details there. There's a dedicated phone line and an email address, and of course our dedicated web page. So that's pretty much it. Hopefully that's provided you a bit of information about how your personal insurance might be able to help you in this current time.
Bruno, thank you so much for sharing your time today, but mainly for AFM, I'm going to say AFM, that's going to be easy for me to remember, AFRM, joining and partnering with Myeloma Australia, because I know there's been a buzz amongst my colleagues. It's been a long problem for our members. Financial toxicity is a huge burden, and anything that we can do to support that and relieve that with your knowledge and experience is going to be an incredible asset to our arsenal of support. So thank you very much for being here today.
No, thank you for the opportunity. And look, you touch on a really good point there, Megan. Financial toxicity is real, and we when we're speaking to patients and clients, we're hearing about that quite a bit. And to be able to alleviate some of that stress is significant, so that they can continue treatment and so forth, is really important to us. We want to be part of the solution, and then part of our partnership also, and I didn't touch on it earlier, but I should do, is we're looking to make a financial contribution back to Myeloma Australia biannually, so that it goes towards the telephone support line as well. So we're big on making a difference here, and thanks again for all of those online who were hopefully able to take something away from today.
Great. Thanks, Bruno. We're going to close our session here today. So I want to thank all of our speakers that have joined us, and my beautiful co-chair, Jo, who's been helping us with all of our background, and Alicia on the support line. We hope that you found today's session informative and inspiring. Please don't forget to send through any questions to our nurses email for any of our sessions today. That's nurses@myeloma.org.au, or you can call through the support line 1800 693 566. We really love good, robust feedback, so don't hold back. We need it to improve our seminars and services. So if you can just take a minute to fill out our survey on the website, it's down below. We would really appreciate that. And finally, most importantly, remind all of you that this is your month to share your stories with friends or anyone that you may have not told or spoken about myeloma much with. We want to spread the awareness of National Myeloma Month as much as possible. You are the multiple faces of myeloma. We want to raise awareness and much needed funds to better support and improve treatments for those living with myeloma. We hope to see as many of you as possible at our 3.8 with a Mate walks. They're in every state of Australia, I believe, and there's also walk where you want if you're not up to hanging out with the crowds. If walking's not up for you, something that you're up to today, maybe just come and cheer us along. We would love to be clapped in at the end or cheered off at the start in our major capitals around Australia. So thank you all for joining us, and we wish you well.